Consultant cardiologist from Mediclinic, Professor Salah Busnan, consultant endocrinologist at Sharjah University Hospital, and Professor Mohammed Hassanin, a consultant endocrinologist at Dubai Hospital, Dubai Health. So welcome to my also long-term friends and colleagues. So our agenda for today will be as follows. I will be presenting the introduction and the summary of the cardiometabolic guideline, and then we're going to have the first case, which will be presented by Professor Hassanin, and then we will move to the second case, which will be presented by Professor Hani Sabur, and then we'll have a short coffee break, and then we will resume our third case with Professor Salah Busnan, and then case 4 will be moderated by myself with commentary from the three faculty. And then we will come to the industry symposia with the, with the conclusion of the cardiometabolic guideline. So without further delay, the cardiometabolic guideline was, aiming to the cardiovascular risk assessment and the management in patients with dysglycemia. And I take this opportunity to thank the steering committee, Dr. Wael Al-Mahamid, consultant cardiologist at Cleveland Hospital, Abu Dhabi, and Professor Hassanin, and also Professor Hani Sabur, for their hard work and dedication, and they are the main force who had drive to the development and implementation of the cardiovascular guideline. And I also cannot forget all my colleagues, the co-author, including Professor Salah Busnan here with us today, and the other co-author of this cardiometabolic guidelines. They are all key opinion leader across UAE, from the private and also from the public sector, and they are from both society, including the Emirates Diabetes Endocrine Society and the Emirates Cardiology Society, for their, again, hard work and dedication to drive this guideline also to the, to what we have it currently. And also we had a support from Professor Costantino, who is the Vice President of the European Society of Cardiology, who had helped us to, with this guideline for his final touch and review of the guideline. So many thanks for my colleague. They've been also actively involved in presenting the cardiometabolic guidelines, and they took part in the workshop which we had conducted over the over this weekend. So some of our colleagues who are not with us here today, they were also presenting in Abu Dhabi, in Al Ain, as well as in Dubai, and today we are in Sharjah. So as you are all aware, the cardiovascular disease is the most prevalent cause of mortality and morbidity in people with type 2 diabetes. And as you know, that the cardiovascular disease frequently coexists with other cardiovascular risk factors, which are the hypertension, the obesity, and the dyslipidemia. And we know that the WHO also had predicted and projected that there is a rapid increase in the risk factor in UAE. So let me take you to a Waqaya data. Waqaya program, which was initiated in April of 28 in the Emirates of Abu Dhabi, in our capital, and that was a government-free insurance program for the UAE national who are residents of the Emirates of Abu Dhabi, all those individuals between the age of 18 and 79 years of age who wished to be enrolled in this free government insurance program. They underwent cardiovascular screening process. So let me take you to the prevalence of all the cardiovascular risk factors that had been taken place, which include first the obesity, and as you can see, the prevalence of obesity in this Waqaya program was 35%, with more predominance in female compared to male. While the overweight overall prevalence was 31.9%, with more predominance of overweight in men compared to females, with a central obesity more common in male with a prevalence of 54%, and also dyslipidemia was 44%, and again it's more predominance between men compared to the women. While hypertension were more or less is the same between females and male with a prevalence of 23%, and smoking, as you can see, is more in men, 25.8%, while female 0.8%, which is underestimated, and you're going to see that in other publications that took place on the subsequent year, there were more of female who is also smoking in our society. Then 27% of the prevalence of prediabetes, so we have a high prevalence of prediabetes, and 17.6% of diabetes. So as you can see, we have a high prevalence of cardiovascular risk factor that we need also all to tackle. Now there's one other publication which looked into the prevalence of prediabetes in UAE, which range between 8 to 17%, while the prevalence of a newly diagnosed diabetic range from around 3 to 13%. Unfortunately, among UAE national, we have a high prevalence of diabetes in the country. And also we are seeing of a high prevalence of prediabetes among our expats who are residents of UAE. So if you could look now at the prevalence from Dubai Household Survey, which was conducted in 2019, and I have the privilege myself and Dr. Hassanin to take part in that, you can see that the prevalence of diabetes among UAE nationals is 19.3%, which is the green bar, and among expat is 12.4%, and that's in the Emirates of Dubai. So that put the Emirates of Dubai with a high prevalence of 13.7%. And this is not different than what we have seen from Wuqaya data, rather than also from the Ministry of Health and Prevention, their household survey as well. So we have both prevalence of diabetes and prediabetes is high. And as you can see that UAE is witnessing a rapid surge in the cardiometabolic factor, and we have almost 85.1% of our population are physically inactive. This is what we have seen from our Dubai Household Survey. Now, there are several publications, as I told you. One was the Wuqaya, the Dubai Household Survey, and also Ministry of Health and Prevention had published, prevalence, but they are more or less are the same, with an overall prevalence of overweight 40% and obesity 31%. This is from the Muhab data of 2017. Hypertension from Wuqaya data, you have seen 23%. From Dubai Household Survey of 2021, even the hypertension was high, 32.5%. Dyslipidemia from Wuqaya data of 2012, 44.2%. A sedentary lifestyle, we have only 17% of daily moderate physical activity of our population, and that's from Dubai Household Survey 2014. Smoking, as I told you, in men was 21.6%, and women, as you can see here, I show you in Wuqaya data it was 0.8%, but from the Muhab data it's even higher, 1.29%. Diabetes from Wuqaya data is 17.6%, and from Dubai Household Survey, 19.3%. So as you can see, we have a high prevalence of all cardiovascular risk factor, and we have also more of less physical activity and sedentary life. And we are all aware, and I don't know how many of you here from primary health care physician, but we all in UAE aware that 90% of people with type 2 diabetes are treated at the primary care physician clinics. And the average visit to the PSC doctor is too short in order to do a comprehensive cardiovascular risk assessment or look into or to address all the cardiovascular risk factor in those who are at a high risk. And if we don't address these cardiovascular risk factors at a timely manner, then these patients will be ending up with ischemic heart disease, with ischemic stroke, peripheral arterial disease, and also congestive heart failure. And you are also aware, you've been also attending many conferences, workshops, and also sponsor meetings. You know that there is a paradigmal shift currently from just focusing on a control of HbA1c, on just controlling the glycemic control, to more organ protective approach. So there's a significant improvement in the cardio-renal outcome with the use of the new generation of medication like SGLT2 and GLP, coupled with controlling all of our traditional cardiovascular risk factor. Also, the European Society of Cardiology 2019 guideline had included evidence from the cardiovascular outcome trial, which had emphasized on the need for this approach. And then the American Heart Association 2022 guideline have been constantly confirming the same approach. And recently, which we did not put it on the slide because when we published the guideline, the ADA guideline 2023 standard of care also emphasized on the same same, approach. So as you can see, all the major societies, whether the diabetes or cardiology society, all emphasize on the same. Now let me take you to the roadmap for the cardiometabolic guideline, which was important in order to address to all healthcare provider to when to refer and how to approach person with cardiometabolic disease. The idea had generated between the steering committee, that's Dr. Wild, Dr. Hani, Dr. Hassanin, and myself, when we were preparing for other activity with American Diabetes Association and with the American Cardiology Society, when we thought in December of 2021, why not to have a guideline of our own, of course, looking into the international guideline and modifying it in order to suit our community. So, and then between the Jan to April 2022, we started setting the scene and the preparation. And then in April 2022, we had our first kickoff meeting where all the co-authors of the guideline, we met face to face. And then between May to November 2022, we started already, several face-to-face meetings, draft, email communication, WhatsApp communications between all the group of the co-author. And eventually in December 2022 to January 23, where the steering committee met back and looked into the draft in order to fine-tune it, and then eventually the guideline was published in the Dubai Diabetes Endocrine Journal. And in February of 2023, we launched the Cardiometabolic Guideline during our annual meeting of our society, the Emirates Diabetes Endocrine Conference. And I just want to emphasize that this guideline had been supported by unrestricted grant from Novo Nordisk, UAE, and they have no interference or input in that guideline. This guideline was done solo by all the co-author of the program. So that was for the first time now, though we have many activities with the Emirates Cardiology Society in the past, but this is the first collaboration between the Emirates Diabetes Endocrine Society and the Emirates Cardiology Society to put hand in hand to, in order to publish this guideline. So this collaboration was very helpful, and it's showing that the multidisciplinary approach or the new trend of how we how we treat our people with diabetes. So these guidelines are directed toward the primary care physician as well as the specialist for early recognition of a cardiovascular factor in people with prediabetes and diabetes. And as I told you, this guideline had been published in the Dubai Diabetes Endocrine Journal, where you can download the full publication free of charge. Now, we have also to understand that we have additional vigilance is needed for the diverse risk factor in UAE. Our population, who develop, premature atherosclerosis, cardiovascular disease, or heart failure, or AF, they are young population, and we have also a high-risk population with multiple risk factor, as I've just shown you from Waqaya data. We have a high prevalence of young patients who are smoker, who are obese, and they have metabolic syndrome, and we also have seen 85% of our population have sedentary lifestyle, and if the patient, if they are not physically active, then that will mask their symptoms of coronary artery disease, congestive heart failure, and you may miss those patients who have diabetes with other cardiovascular risk factor. So now let me take you through what we had put in this guideline in terms of screening and diagnosis. Now, who should we screen? We need to screen all patients with prediabetes, those with type 2 diabetes, and adult with type 1 diabetes who are above 10 years duration of diabetes. Now, how to screen them? First, it's very important, as we had learned from our medical school, the detailed medical history is very important. And that detailed medical history needs to remain with us from undergraduate till the time of our retirement from this field. So it's very important to ask your patient simple question about symptoms of cardiovascular disease, if they have chest pain, shortness of breath, if there's radiation, if there's exertional dyspnea. It's very important to ask them about symptom of claudication, if they walk, if they have interrupted walk, or they have pain in the calf. You need to ask about the smoking status. And of course, you need to do a thorough physical examination by measuring also their blood pressure, BMIs, peripheral pulses, ABI, and also you send them for also retinal examination. It's important. We have to do also investigation, which is specifically targeting those type 2 diabetes with cardiovascular disease, which include ECG, pro-BNP, and high-sensitive CRP, and high-sensitive TNT, which is done at the physician discretion. And you will learn from my colleague when they do their case presentation more detail about that. Also, we need to measure their serum creatinine, estimated GFR, and urine for ACR. Also lipid profile and also CBC, because now we are all aware that anemia is an issue for people who have heart failure. That's why it needs to be corrected, and we need to look at the HB as well as our iron profile. HbA1c, of course, is important as part of our metabolic checkup. Now, we all know that, the traditional, risk factor that we always annually we assess, which is on your left hand of the screen, which is the ECG, which is the foot examination, which is retinopathy, and also GFR and urinary albumin creatinine ratio. So what we had added in our UAE cardiometabolic guideline, plus all those traditional factors that I just mentioned, we need to do the pro-BNP, and we need to do ABI and coronary calcium score, which you will hear more about it from our cardiologist, Dr. Hani Sabur, shortly. Now, how to screen our patient? There are two main things for the screening here. One is the symptoms and signs of cardiovascular disease or peripheral artery disease, and also heart failure. As I told you, you need to ask about the chest pain specifically. You need to check for edema. You need to ask about dizziness. You need to ask about palpitation. You need to put your hands and check the pulse of the patient if they are having irregular pulse like AF. You need to ask them about their fatigue, about their effort intolerance, about the syncope, or about intermittent claudication. And also, you need to measure the ankle brachial index, which is the ABI, which I don't know it very well, but I'm sure Dr. Hani will explain it more in detail when he do his case. Now, how frequently we screen? We screen annually, and for people with pre-diabetes, consider screening 2 to 3 years, every 2 to 3 years, according to the number of cardiovascular risk factor. And who we should consider screen positive? All those who have abnormal physical examination, those who have abnormal peripheral pulses or ABI, and those who have abnormal retinal examination, plus those who have abnormal investigation, including ECG and pro-MP or serum creatinine, estimated GFR, or ACR. Now, how to manage those who screen positive? So you screen them, you did all your examination, you did everything, and they screen positive. Now your role is to refer them to specialize, for example, to endocrinologists for their sugar control, to cardiologists if you find any cardiac problems, and also to vascular surgeon if you have peripheral vascular disease, or you may refer them to all cardiometabolic if the patient having all the cardiometabolic problems. Also, you need to address all their lifestyle measure, including that smoking cessation, so you have to send them to smoking cessation clinics, weight management, and also encourage them for increased physical activity, and you may require also the input of your diabetic educator and your clinical nutritionist to support them with that. And then you need, as an end users or at a healthcare profession, to treat all their cardiovascular parameter as per very high risk group. Now, what will happen to those who screen negative? Do you need to just stop there? They screen negative and you are at ease? The answer is no. You need to apply UAE cardiometabolic diabetes risk score, which we, our colleague who did the guideline, all the authors, we came to this consensus. So what is the UAE cardiometabolic risk score? It depends on 3 domains. 1 is the age of the patient, 2 is the duration of diabetes, and 3, the number of risk factor. Age of the patient, if the patient is above or equal to the age of 40, then they score 1. If they are age less than 40, then they score 0. If duration of diabetes is more or equal to 10 years, then they score 1. If duration of diabetes is less than 10 years, they score 0. And if they have, then we depend on the number of risk factor. If you have multiple cardiovascular risk factor, then they score 2. 1 cardiovascular risk factor, they score 1. And no cardiovascular risk factor, they score 0. Once you do that calculation, then you need to apply it to come up with the cardiovascular risk category. So if they score 4, then they belong to this red group, which is very high cardiovascular risk. And if they score 3, then they belong to the high cardiovascular risk. And if they score 2, then they are moderate, cardiovascular risk, and if they score 1, then they belong to low cardiovascular risk. And then, of course, for screening, as we said, we need to screen them all. Whatever is the risk categories, they can be screened annually, with exception of those who have prediabetes, 2 to 3 years, and also depending on their cardiovascular risk factor. And why the cardiometabolic risk factor is important? Because this will help you then in tailor the management for those patients. And I'll take you through that management, which you're going to hear also more in your cases when you do the cases. Now, if the patient belongs to very high cardiovascular risk factor, then you need to start the patient on SGLT2 or GLP, regardless of their glycemic control. But if they are above glycemic control, then you need to combine both the SGLT2 and GLP together. And then you need also to target their blood pressure should be less than 130/80 using either ACE or ARBs. And you aim for an LDL cholesterol which is less than 55 milligram per deciliter using a high intense statin. And then, of course, antiplatelet is indicated. If the patient belongs to the amber color group, which is a high cardiovascular risk, then the SGLT2 or GLP is not routinely indicated, but if their blood sugar control is above target, then you use either or SGLT2 or GLP, and if still they are above the target, then you combine them together. Aim for a blood pressure which is less than 130/80 using ACE or ARBs, and LDL target less than 70 milligram per deciliter using a high intense statin, and antiplatelet may be considered. Now, for those who are moderate cardiovascular or low cardiovascular, again, the SGLT2 or GLP is not routinely indicated, and if their glycemic control is above target, then you need to apply the Emirates Diabetes Endocrine Society Consensus Guideline for the Management of Type 2 Diabetes 2020, which we had published years ago, but the good news, we are updating this shortly, and we will launch it for 2025. But as you see, that there's not much had been different, because if you go to the standard of care of ADA, which was published in 2023, more or less, we advocate to the same thing. But we would like to encourage you to use our local guideline. And then you aim for a blood pressure. If your patient is a moderate cardiovascular risk, you aim for blood pressure which is less than 130/80 using any antihypertensive agent, and the same thing is applicable for those with a low cardiovascular risk. For LDL, if it is moderate patient is moderate cardiovascular, then you aim for an LDL less than 100 and use any moderate intense statin. And for a low cardiovascular risk, your target will be less than 120, considering a moderate intense statin, and the antiplatelet, it is not indicated. It's very important that management of type 2 diabetes with cardiovascular disease, it's a holistic approach. It's not just all about medication, SGLT2 or GLP, but also you need to tackle all other lifestyle-related issues, which include that you should encourage your patient for healthy eating, weight loss, smoking cessation, regular exercise, to sleep well, regular checkup, and also to manage their stress and to become more physically active. And we have seen this in the success from STENO2 study, which shows that intensive multifactorial risk factor control after 21 years had reduced the mortality and morbidity of these patients. And also we had seen from the Swedish National Diabetes Registry, where the author had looked into 271,000 patients with type 2 diabetes and matched them with an age group and sex and country match, and then they followed the patient for about 5.5 years, and they looked that there is an excess of acute myocardial infarction due to failure to control the multiple risk factors, which include the hyperglycemia, hypertension, and hyperlipidemia, proteinuria, and smoking. So it's very important to tackle those factors, and this is what happened when they did not control them, then they were more risk of cardiovascular event. So with this, with this introduction and summary of the cardiometabolic guideline, I thank you all for your listening, and I now, will invite Dr. Hassanein to present his first case, but please, I appreciate that, this is an interactive workshop, so we want to hear also from you as much as you want to hear from the faculty. Please do not feel shy, to come forward with any questions and suggestions. There will be a cue card, will be showing on the screen shortly, and also you have it printed on the table, so please use your mobile screen, and then you can, answer when the polling question will take place. Also for those who cannot, they are shy to speak, and I don't want anyone to be shy here. We are a small group. The app itself have the facility that you can post your question, and we will be also projecting this question. Yes, Dr. Hani, please. Muhammad will cover it in his case. Okay? Okay, Muhammad. Thank you.